Okay, dear Professor Xie, Professor Zhang, Professor Fong, and Professor Liu, I'm Dr. Xue Yumei from Guangdong Provincial People's Hospital. And this session will be chaired by Dr. Zhang Jining and me. And here we will discussing the concept and using experience about pulse field ablation. We invited four speakers from uh, Hong Kong, from Singapore, and Dr. Zhang from Wuhan, and Dr. Liu Qiang from Zhejiang. Okay, and PFA is a new energy, yeah, and almost widely used in arrhythmia treatment at present. At first, let me invite Professor Xie Hongfa from Hong Kong, from University of Hong Kong. Dr. Xie is a famous electrophysiologist and famous cardiologist almost around the world, and very welcome in China and in Asia. So his topic is biophysics of different PFA. Dr. Xie, please.
Thank you for the invitation to this current practice in Asia from the Asian Heart Society. So I would like to present a talk on the latest advance in the pulse field ablation in atrial fibrillation and show some of the experience in Asia. This is my disclosure. If you look at the disease burden of atrial fibrillation, so this is one of the recent study. We actually look into a survey to look at the potential disease burden of atrial fibrillation in Asia Pacific area. As you can see here, there's a huge disease burden in Asia Pacific. It's almost up to 80 million of people who suffer from atrial fibrillation as comparing to the number you see here in the United States and European country. And obviously, in the management of atrial fibrillation nowadays, catheter ablation play an important role in managing a patient, reducing symptom, and potentially improving the outcome in those patients. In terms of patient selection of AF ablation, you can see that obviously a patient population, obviously patient will have a good left atrial function, but poor left ventricular function have been demonstrating that AF ablation does improve symptom quality of life and reducing MACE. On the other hand, also good patient who are symptomatic, who also still have the good left atrial function and also good left ventricular function, were able to improve symptom and quality of life with using catheter ablation. Indeed, if you look at all the guidelines latest from the ESC, you see that catheter ablation become one of the important in patient with paroxysmal atrial fibrillation as class 1 indication, and in patient with persistent or atrial fibrillation with a class 1B indication for treatment. And if you look at the efficacy of catheter ablation versus medical treatment, you can see that the catheter ablation significantly improve outcome comparing to medical treatment.
Thank you, Chairman, for the kind introduction. It's a pleasure and honor for me to share with you my initial experience using pulse field ablation in treating atrial fibrillation. These are my disclosures. We had the good fortune to use pulse field ablation from October 2022, and we published the results of the first 100.
Okay, what's the matter?
放错了吗？
对，是什么情况？谢红发教授。 哦，这叫做出什么问题了？
不是啊，我就做这个 video，不记得为什
哦
么不能放出来，这是 video 的。
哦，可能要 share your screen again。
我可以现在再试一次的，可以。我可以现在放进这个 share screen 嘛？
Okay, you share your screen again.
可以吗？
哦，OK，可以，OK，Great。
Okay. Okay, so sorry for the interruption. So I will now present the talk again on live. So obviously one of the limitation for the current catheter ablation is actually the potential complication. In particular, some of the life-threatening complication that relating to the use of thermal energy, as well as severe complication like the pulmonary ring stenosis. And I think the advantage of PFA is actually the unique advantage of different energy source in terms of when you're using electroporation, there are different tissue specificity in terms of inducing tissue injury. In particular, the energy we actually need to myocardial insult is actually much lower than the in comparing to the use of other energy for other tissue, for example, including the nerve, endothelial, and also red cells. So as a result, they're actually improving the safety and potentially reducing complication for the AF ablation. So if you look at now a current multiple technology available in the market, so this is slide showing multiple different catheter design now available in different countries. So including a circular catheter, the common use one, including the basket kind of design. They also have a focal catheter and also a different circular catheter, large focal basketball, and including they using different electrode configuration, either using monopolar or bipolar configuration. And also waveform, they also can using a long monophasic, biphasic, and different type of waveform. And if you look at the target, obviously, they will also relating to the ablation for atrial fibrillation. And some of them actually can combine with the 3D mapping technology. And also now they also have focal ablation catheter can also can combine with some of this 3D mapping system. If you look at all the available parameter you can adjust, obviously you see that there's a many parameter you can adjust with the PFA. So in terms of voltage, waveform, fundamental frequency, the pocket duration, number of pocket, and pocket delivery stages. So each of the parameter can change. And when change each of the parameter, then associating in terms of different effect on the lesion size. For example, if you're using increasing energy, duration, you have bigger lesion size. On the other hand, if you're actually using different voltage, you also away from also have more muscle stimulation. On the other hand, if you actually have very high voltage, high duration, you also can need to thermal effect as a result and need to increase risk of temperature as well as thrombotic risk. And also you can have different electro breakdown risk associating with different energy. But when you get to very high energy, they can also can lead to a tissue pop and barrel trauma risk relating to the energy. One of the most early use is actually using Farapulse PFA that including either a basket configuration and also they can change to a file configuration, which allow a effective single pass ablation for PV isolation. But on the other hand, the file configuration can also be allowed to using for posterior wall ablation, again, could allow a much wide area ablation in the antrum and as well posterior wall. So this is the initial clinical trial using the FARAPULSE PFA, using in different group of patients, but also different center. Again, what been very remarkable with the PFA is see that with different center, different location, you have very consistent efficacy in terms of ablation. That means they're much less operator dependent in terms of making effective ablation for PVI isolation. Obviously, if you look at overall, there are certain areas can have potentially gap. So if you look at mapping some of the area, if you're just using a single pass ablation, some of the potential area may be missing. So that's why in subsequently some of the area, if you're able to using 3D mapping, we need to pay attention. Like for example, the anterior area in the right superior and inferior pulmonary vein, the superior aspect of the left superior pulmonary vein, and also in the carina region in the left lower pulmonary vein. The other application, as I mentioned, the PFA also been tried to doing posterior wall ablation. And so in this recent publication, they're also demonstrating that in patients with persistent atrial fibrillation, we're using additional posterior wall, at least it's safe and may have improving efficacy. If you're comparing the safety endpoint complication, it doesn't actually increase comparing to just doing PVI alone. So this is kind of workflow. I'll show you that it will perform in a center. You usually start with a CT pulmonary angiogram to look at anatomy so that you can see that, like in this case, there's a common ostium in one of the vein, so that we can actually target our lesion and also decide where we actually go for in making the ablation set. And then this is the baseline map using the FARAPULSE and using the Orion system to map the atrium. You see, this is the baseline mapping. And then we start from the PVI isolation here. As you see here, we start from the basket and then using file configuration to complete the PVI isolation in all the pulmonary vein. As you see here in electrogram, you have very effective single pass ablation to eliminating to perform PVI isolation. And after that, we navigating through this 3D mapping system. Firstly, we can able to navigate to see our catheter position and contact during the ablation, but also allow us to design our lesion sets in ablation of atrial fibrillation. And this is the 3D mapping after the PVI isolation. You see very nice homogeneous isolation in this common ostium and all the other superior pulmonary vein and inferior pulmonary vein in this particular patient. And then we go on to do posterior wall isolation using this system. As you see here, we put in the catheter in the posterior wall. And again, this is post-ablation. You see very effective and homogeneous isolation of posterior wall in this patient. And interestingly, while we actually perform the posterior isolation, the atrial fibrillation actually convert to atrial flutter, as you see here. And then we do a further mapping and confirm this is a left mitral isthmus flutter. So we go further perform linear ablation from left inferior pulmonary to mitral valve annulus. As you see here, we perform this using the file configuration and achieve a conduction block within here. As you see here, after the mitral isthmus ablation, you see a termination of atrial fibrillation back to sinus rhythm, and then we are not able to re-inducing atrial fibrillation in this case. Other technology also been demonstrated. This is another catheter design from Medtronic, which is also select-driven, a circular catheter. Again, similarly, they can also combine with a 3D mapping system and able to show in different population with paroxysmal and persistent atrial fibrillation, very consistent 70 to 80% efficacy over long-term follow-up. Again, the most important aspect is actually rare safety in terms of application. Other similar design, this is from the J&J, also it's a circular cath design combined with 3D mapping. Again, you can achieve that very effective first pass ablation in the majority of case, and in terms of long-term efficacy, you see almost 87% again in terms of outcome in PVI isolation in this population.
So this is our recent experience for using this system. Again, you can using combined with Kato to allow a 3D mapping. So you can see this is we start from using this circular catheter to perform a 3D mapping before the ablation. And then we can also navigating with the system. So here, this is the baseline map. This is a lesion set with the PFA ablation. And this is after the ablation. You can see we map very nice PV isolation in this particular case. The other potential catheter design, including this large basket with the PFA catheter, again also allow a single pass PV isolation. Again, you can see that with 3D mapping, they also have a very effective isolation. So it appears that whatever the catheter design, you have very consistent efficacy, about 70–80% in terms of long-term follow-up for this PV isolation. Another similar interesting design is a balloon in a basket PV isolation, acute efficacy 99%. Again, they can combine with the 3D mapping system. This is a R-board mapping system. And then you can see that in patient population with paroxysmal persistent atrial fibrillation, you can get up to 76 to 99, 88% efficacy. Again, very reassuring safety data in terms of major complication occur in 2.7% of population. So if you look in the future, what the other important advances is maybe in the future you can combine different energy. Like the show here, some of the catheter can only will allow to perform PFA, but the other can combine with a radio frequency, and maybe even in the future they can also talk about ultra low temperature cryoablation. Some of them are tissue dependent on tissue contact, and some of them have low risk or high risk of thrombogenesis, and some of them, especially PFA, may have a tissue specificity. The idea here is if you're able to comparing a different energy source, for example, you were comparing radio frequency uses PFA, you can see that thermal energy and PFA actually give rise to very comparable in terms of efficacy. But again, most important thing, you probably have a shorter procedure time and also very comparable overall complication rate shown in this trial. Again, this is a overview of different thermal energy, like including radio frequency, cryoablation versus PFA. As you see here, the overall acute efficacy is very similar in acute PV isolation. But if you look at the long-term outcome, there are much more variability in terms of long-term efficacy, in terms of radio frequency and cryoablation. But I think the very interesting phenomenon, whatever the catheter design and also the waveform, you can see a very homogeneous efficacy in terms of PFA, in terms of long-term efficacy, independent on the so many different type of catheter design, as well as different kind of waveform. So I think this, again, is very important in terms of long-term application. Again, if you look at the safety profile, again, you can consistently see whatever in all the trial, different PFA energy are consistently associated with less major severe complication like esophageal damage, pulmonary stenosis, phantom nerve injury. But some of them actually have been associating with muscular stimulation because of post-field ablation. And this is one of the limitations. In a lot of cases, you probably need to undergo using general anesthesia for doing that. However, some of the latest waveform, you may be able to have less muscle stimulation. As a result, you may actually have less utilization of general anesthesia. There are certain particular complications because of the biophysics of PFA, that including hemolysis, which occur initially observed with the peripheral, but also been demonstrated in other PFA energy. It obviously relating to the amount of PFA delivery, the contact, but in general, you actually allow a very effective hydration. You're actually minimizing the potential acute kidney injury with that. The other important complication is actually coronary artery spasm, the PFA. So this initial period experience in the mitral tricuspid isthmus. When we are ablating through the tricuspid isthmus, they can lead to right coronary spasm. And also similarly, in mitral isthmus, you can associating with the circumflex artery coronary spasm. However, you're able to give nitrate during the ablation, you can actually eliminating that. But there are also some other OCT imaging studies show that they actually have some minor degree of endothelial damage. So again, we try to limiting the amount of ablation in the vicinity when you're close to the coronary artery in those cases. Again, what I mentioned here is if you now in the future with different energy design, like some of these large circular, if you're using a low lead frequency of muscle stimulation, potentially you can actually done the procedure under local deep sedation, and then most important, you actually can reducing the procedure time, but avoiding general anesthesia. The other potential application in terms of biophysical application is maybe in the future you can hybrid the energy, as I mentioned earlier on, in addition to using the catheter for PFA. And in addition, you may actually in different scene location using hybrid with radio frequency energy to give a much deeper ablation. So this is one of the initial system. We can also provide PFA and radio frequency ablation so that you can tailor make the lesion set like in the posterior, or when you worry about tissue damage, you're using PFA. In the anterior, which you want to get a much deeper ablation, then you can using radio frequency. Again, this study also showed the feasibility by using this combined energy. In fact, you're using a direct comparison with this combined approach versus direct thermal energy, you again see very comparable terms of long-term efficacy, relative lower risk of complication similar, but most important, you see a significant reduction in the procedure time. So this is another system been available in China that using a much lower frequency and as a result less muscle stimulation. And again, they can combine with a 3D mapping system for PVI isolation. One of the advantage of using this is actually with this kind of a system, you're able to also using radio frequency as well as a PFA, and also can potentially eliminating the use of general anesthesia until reducing procedure time. And one of the advantages is this system also have a single point ablation that can potentially using for ablating in area you worry about damage of conduction system like AVNRT or septal pathway. Again, this initial experience demonstrating they may be safe and effective for doing this ablation in those areas. So in conclusion, I just show you a different PFA technology, single shot point by point. It will providing simple and fast, effective energy source for air ablation. And the clinical efficacy show in clinical trial demonstrating that actually that compared to thermal energy are probably similar in terms of efficacy, probably less collateral damage, but overall complication similar because of other new complication like coronary spasm hemolysis. Currently, we still need to wait for any direct comparison between different PFA technology, but I think in the future, maybe point by point PFA or combined with radio frequency energy with 3D mapping will be the future to allow more effective AF ablation. So with that, thank you for your attention, and I welcome any comment and question.
Okay, thank you very much, Professor Xie, and very wonderful speech. And I just have a question. So many kinds of new catheters present, yeah, the circle shape, the basket, and balloon in basket, and also the points, and also dual energy type of, so many kinds of PFA catheters. So which one, if you can select, which one do you prefer?
Well, I think in different cases, if you just want to do a simple PVI, I think the single shot like Farapulse basket will be very effective. And however, in some of the area, if we want to make more linear ablation, like for example, more complex cases associated with atrial tachycardia, maybe some of this hybrid energy with point by point ablation that may eliminating the potential complication like coronary artery spasm because you don't need to ablate so wide in terms of the mitral and tricuspid annulus. But again, we still need to some of the study to look at which energy or which kind of platform is the best. But I think in the future you'll see that will be a lot of hybrid like radio frequency and also PFA in the same system, so they allow more flexibility in terms of ablation.
And in your appearance, should we take more care about the hemolysis? In your opinion, the hemolysis is common or just how
Yeah,
can
so
yeah.
yeah, we try well, 2 or 3 different PFA. All of them, if you check all the parameter, they will actually have some form of hemolysis in most of the cases. So especially when you need to do a lot of ablation. So number one, if you don't need to ablate that many, so you try to limiting the amount of ablation. Secondly, now we tend to using a hydration protocol. We make sure we put the patient on hydration before the procedure, and also after the procedure. If the patient not in heart failure, we give extra hydration. So that most of the time, that hemolysis actually don't inducing a kidney injury. So I think this is very important. But I don't see a very severe long-term consequence in those patients. Obviously, there may be a limitation in some patients with heart failure. You cannot make a lot of hydration. That's why in those patients, maybe some of these new ablation system with combined radio frequency in some area, you don't want to make too much of PFA, then maybe switch to RF and also can be eliminating some of this complication.
And do you ever use the balloon in basket catheter? They said some data suggests that in this kind of catheter, the hemolysis maybe yeah not so so serious. Yeah.
Well, it depends on the catheter contact. So as I mentioned, the contact will be very important. So maybe the balloon one will actually make a better contact so that we're eliminating the risk of hemolysis. But also, I think even for FirePulse now, we also combine with the 3D mapping system. So initially, when we're just using fluoroscopic guided, they maybe have less tissue contact, so they're high risk of hemolysis. But if you're able to using 3D mapping to also monitoring the content, it will also reducing the risk of hemolysis in long term.
Okay. Okay, thank you, Professor Xie. Yeah, you give us a wonderful speech about the evidence about PFA and also your own experience in this field. Thank you very much. And because of the limited time, we move to the next speaker. Okay, thank you, Dr. Xie. Yeah, the next speaker is Dr. Zhang Jingling from Asia Heart Hospital in Han. His topic is clinical experience with PFA in persistent atrial fibrillation. Yeah, Professor Zhang is a famous electrophysiologist in China, and he have published many useful and wonderful paper about different kinds and atrial fibrillation and ablation for different kinds of cardiorhythmia. Yeah, very experienced EP doctors. Okay, Dr. Zhang, please. Yeah.
Okay, thank you. We show the slides. Okay. Okay. Tonight we'll focus on the introducing our experience of the PFA in the mitral isthmus ablation. We all know in the persistent atrial fibrillation, the mitral isthmus block remains a great challenge for the radio frequency. But in the PFA, we can see these large and homogeneous lesions, and which we can achieve using the radio frequency ablation. So we use this FirePulse PFA, especially in the large atrium and the persistent atrial fibrillation. We focused on whether this PFA can block the mitral isthmus line. Here is the workflow of our center in ablation persistent atrial fibrillation. Nowadays, we didn't know if we need to do the SLO ablation of the martial vein in the PFA era, but today we still do the SLO ablation of martial bundle in most cases. So the strategy for our center is mitral vein iso first, then the PVI isolation and the post-wall box lesion, and the mitral isthmus ablation. Sorry。诶，我的窗口不见了。等一下，不好意思，我的屏幕怎么看不见？我怎么屏幕变成了一个讲者屏幕？我看视谱。哎，我怎么看上去全部是我的讲者视频了？是点错什么键吗？
我们看的是好的。
不是出现共享，是把这个讲者屏幕把我的幻灯片挡住了。我是点了什么键了吗？你看得到我的幻灯片是吧？看不到，那我就重新
重新分享一下。
不好意思，不好意思，看看。
OK。
现在看得到啊。
OK。
So we do the up to date. We do the more than 20 cases of mitral ablation, and the first pass mitral isthmus block is 86%. It's very surprising because when we do the radio frequency, even we do the axial ablation, we call the first pass measure is if we cardiac watch the patient, we place the left appendage to check the mitral block without any additional gap or ablation. So this first pass mitral block is surprisingly high in the PFA. And after we finish the gap ablation, we achieved all the cases of the mitral block. So today we use still the two-dimensional Farapulse catheter, and we use the right angle, right optical angle 30 degree, and we just rotate the catheter from the left inferior pulmonary vein to the mitral annulus to finish the mitral ablation. And after that, we do the high density mapping, use the rhythm system to make sure to do the replace the left appendage to make sure the mitral isthmus is blocked by high density mapping, activation mapping, and also the substrate mapping to see what we cause the injury in the atrium. And we also use the traditional pacing to see the sequence of the cortisolus, and we do use the differentiation to further to confirm the block of the mitral isthmus line. So this is one case. You see, we finish the PFA and we place the left appendage, and you see the activation blocked at the mitral isthmus line, and the wavefront rotate on the counterclockwise direction, so it confirms the mitral isthmus block. And you see the large lesions of the posterior wall box and the mitral isthmus region. This even in the ridge, you see, in the ridge there's no potential. So we didn't see we didn't call it. I think it is not appropriate to call it a linear ablation of mitral isthmus. Even we can now call the isolation of the mitral isthmus. I don't know, but you can see the vast region of the scar encompassing most of the regions of the mitral is different from the radio frequency. You can see the large lesions we made, and then the PV isolation. So we also checked the traditional method to different patients and see all the lines blocked. This is another case. This you can see that massive. In this case, we didn't do the acid ablation, so we can see still some potential remains in the ridge, but also the mitral isthmus was blocked. Although the lesion set was relatively narrow, but it's still blocked. But in most cases, we didn't achieve that because you want to block the mitral line, you should ablate a large scale of the during the endocardial ablation. But we were focused on those cases, those remaining 10% cases where we didn't achieve the first pass mitral isthmus. So where is the gap? Where can we find the gap? This is an important case and give us some indications. You can see here, when we place the left appendage, you can see also the sequence of the cholecyst is proximal to distal, but you can observe some little potentials in the chorus 560 and 34. You can see some blunt far-field potential here. So the activation map also showed the mitral isthmus is not blocked, but we see this far-field potential. We know there's a gap in the endocardium. Okay, so we find the gap here. This is spike potential. This is a little A wave with the gap potential here. So we know this gap is located at endocardium near the mitral annulus. So we ablate here, and the mitral was finally blocked. But the location here, you can see this gap is hidden very near the ventricular side of the mitral annulus. So we give it some indication because you use the FirePulse in the flower mode. Sometimes you can miss the ventricular side, very near the mitral annulus. So we after the following cases, we use the flower mode, especially give some applications at the very little A wave and very large V wave to close the gap near the mitral isthmus. This is our first experience. And in this case, you see that after the mitral isthmus ablation, still the mitral isthmus was not blocked. The wave round crossed the mitral isthmus, and you can see the lesion is not enough because this patient has large atrium, and we puncture the atrial tube posteriorly, so you can't support enough contact of the ferro wave on the ferro pulse on the mitral isthmus. So this case tells us we should puncture the atrial septum more anteriorly, more inferiorly to give support, to give enough contact of the pulse on the mitral isthmus line, so we can give a good lesion. So in this case, we mapped, you can see still some voltage here, and we mapped there is a very early A potential, and we ablated at the endocardium, but it's still not blocked, and we use the radiofrequency catheter in the cholecyst. At the arrow point, we mapped the very early A potential when placing the left appendage, and we ablate here. You can see we block the mitral isthmus line. So we checked the arrow point is almost near the ostium of the mitral bundle. And in this case, we didn't do the actual ablation of the mitral bundle. So we think nowadays, when we use two-dimensional PFA, mitral bundle actual ablation still is warranted in most patients to make durable mitral block, or can save us some time to find the resident gaps. So after the finished gaps, we will still finish the remapping, and you can see this time the mitral was blocked. But in this case, you can see another case. You can see very large post-wall isolation and very wide lesion in the mitral isthmus. But when we place the atrial appendage, you can see the mitral isthmus is still not blocked. Even this is a broad scar, but you can see the activation path jumped through the epicardial conduction to the green point, and still the rotation is clockwise rotation of the wave front. So you can see the mitral isthmus is not blocked due to the epicardial conduction through the cholecyst. So in some we can also use a radiofrequency catheter in the cholecyst to finish the gap, but this time we decided to use the FirePulse to finish the gap in the endocardium. We can see this still in the epicardial endocardial breakthrough. There's still some potential here in the green point, and we check the potentials very early, and we use the FirePulse in the infield mitral isthmus, and we place the left appendage, and we give the application here, and after the application, and we can see the mitral isthmus line from the non-blocked to the blocked with just one application of the PFA in the infield mitral isthmus. So this is give another experience. If we didn't achieve mitral isthmus block, where can we find the gap? We just do more PFA applications in the endocardiogram in the infield mitral isthmus. In this case, we can see we finish the gap, we remap, you can see a massive, vast region of the scar in the mitral isthmus line, and the mitral isthmus is finally blocked. This is before we finish the gap. This is after the gap. You can see the wide, very wide mitral isthmus ablation. So we call it, we didn't call it a linear ablation of mitral. So we can now call it the isolation of the mitral isthmus line. So this is PFA using very possible to finish the mitral isthmus line. You will need very wide lesions in some cases, in just in the endocardium. But in this case, it's slightly different. This is another case. You can see the poor substrate, and we finish the post-wall ablation and the mitral isthmus line. We check the activation map. You can see from the activation map, the mitral isthmus is blocked. You see the activation is blocked on the mitral isthmus line, and the wavefront is rotated clockwise. So from the high density mapping, you are sure the mitral isthmus is blocked. But something hurried me, because you can see when we place the appendage, you see the coleus is not from the proximal to distal. You can see a little earlier of the coleus, middle of the coleus, 50 to 6. You can see a little earlier. From the experience, we are not sure this is really blocked. So we just used our previous experience. We ablated the infield isthmus to do more applications. You can see here the isthmus is not completely blocked, but when we do the application more in the infield, you can see the sequence is now looking very good from the proximal to distal. This is this case another case of the PFA finished gap, but still we didn't understand why the activation map。我完了，死机了。OK，sorry，这电脑又死机了。我看可能退出一下，实在不好意思，动不了了。看看啊 ，sorry，再共享一次。好。好。哎，还是动不了。不好意思，马上重启一下。电影太多，太容易卡。OK， 再共享一下。Okay, sorry. But we remap the color values and we see the true story. Because you can see the propagation here. Actually, this case, the battery supply is really blocked before we just make the application in the infield battery. But why is the sequence of the color values is not very satisfying? Because the cholesterol is put very near the ostium. So this is also, although the line was blocked, but when you place in the left appendage, you can see the activation front move downward the atrial septal and to the connection of the endocardium and the cholecyst musculature here. So from here, the middle of the cholecyst to spread in the two directions. So even though the mitral isthmus was blocked, the sequence of the cholecyst seems unblocked. So what we do, actually, this application is no need, because we do the application, we blocked the endocardium, the epicardial connection. So the cholecyst is isolated from the endocardium, from the proximal to distal. So this is the true case of the story. The mitral isthmus is already blocked, but we do the additional application to block the endocardial, the myocardial connection. The last case is a very tough case. When we finish the PFA application, you can see the mitral isthmus is not blocked. The sequence is from the distal to the proximal. Also a large overall a large lesion of the PFA application. Still, you can see the activation jumped from the epicardial conduction through the cholecyst, and the mitral isthmus is not blocked. And we also do the more applications in the infield mitral isthmus. And after we do the applications, you can see here the mitral isthmus also a large vast of region. It comes in almost all the regions of mitral isthmus, and the mitral isthmus is blocked. But just after we finish the mapping, we observed the 20 minutes. You can see the mitral isthmus block is recovered. Just after we mapping, you can see still from the epicardial connection. So we can do nothing more in the endocardium. So we just put you can see here, even though the endocardium is all smashed with a large area scar, the mitral isthmus is still not blocked through the epicardial cholecyst connection. So we put a catheter here in the cholecyst, and we found the gap, and we ablate, and we finish the. But what is the difference from some cases we just can't block the mitral isthmus in the endocardium use variables? We found some rules. All these patients had very, very large cholecyst with large dimensions. So this is very important. Why can we block the mitral isthmus from the endocardium? You can see the very, very wide with a large dimension of the cholecyst. And in these cases, the epicardial connection is not just at the myocardial side. Is the connection, the myocardial sleeves is also located at the free wall. So you can see you will ablated with the endocardial side, you can't destroy the mitral sleeves in the free wall. So all these cases, with very tough cases, you need to ablate in the cholecyst. This patient has a common characteristic of the very thick or very large cholecyst. So they told us if the patient have a very thick, very large cholecyst, you may need to ablate in the cholecyst to finish the mitral isthmus line, even if you use the best PFA system. So we have several cases of the domestic PFA tools using the single point catheter with the contact force catheter, and we think this catheter is good because when we do many cases, this is such a case where we do the mitral isthmus line, we terminate atrial fibrillation, and we paste the after appendage. You just use 2 lines of the endocardial ablation, you will see the block the mitral isthmus line. It's astonishing to me because this catheter has just the contact force and has a single point ablation. We indicate we didn't do axial ablation, we didn't do any epicardial ablation. We block the mitral isthmus for several cases. So this catheter, single point catheter, has a high rate of mitral isthmus block during the endocardial block. But also we found the use catheter in one case after we finished the mitral isthmus line 2 lines, 3 lines, we still block and unblocked, and we just we checked all the endocardium was late. You can see all the endocardial potential was late. So we went to the epicardium. We used this PFA catheter, but we were worried about the coronary artery space. So we used the vector. We rotate the actor to the endo to direct it to the endo side, and we find a very early potential here, and we just give one PFA, and you can see the mitral isthmus was blocked. So in using this catheter, in some cases in the coronary sinus, you will be aware of the vector direction to induce the opportunity of the coronary artery spasms. But in these tough cases, also you can see this case with very sick, with very dimensioned the large dimension of coronary sinus. So in this large dimension of coronary sinus, the myocardial stiffs is not just in the side of the endocardium, but in the free wall. In this case, what kind of the PFA tools you use, you will still need some applications in the coronary sinus. So in conclusion, PFA in the mitral isthmus ablation, I think is valuable and safe and with high efficacy. The effect is depending on different PFA system, the energy and the different catheter designs, and also you always have tough cases depending on the anatomic characteristic of the patient, especially the dimension of the coronary sinus. And in the PF era, still we needed to answer the question: do we need the axial ablation of the mitral bundle in every patient in the PFA era? Nowadays we have no answers, but we will carry some studies to see if we can find the answer. Thank you for the attention.
Okay, and very thank you. Very wonderful cases. Yeah, and also interesting cases. So with FARAPULSE, maybe it's easier to block the mitral isthmus, but also there are some problems. Yeah, maybe we should combine with ethanol ablation and also ablation in coronary sinus site. Yeah. Maybe with the large coronary sinus, it's very different. It's very difficult to block mitral isthmus in any using any energy. Yeah. How do Dr. Zhang? Yeah. How do you think about the ablation and the dual energy catheter? With the dual energy catheter, we can use RF at first and then plus PFA. Maybe will make a deep lesion in this area. How do you think about the dual energy in this situation? Yeah.
Okay, good question. Because nowadays the data come from the animal study. We didn't have in the clinical study, but I think yeah, I read the paper. It maybe increase the depth, so we will use it in the future. But still, you can see if you met a very wide dimension, the coronary sinus, the endocardium plus the widest dimension of the coronary sinus, it may increase the depth up to more than 10 millimeters. So I wonder if even the dual allergy, if can penetrate this deep, we don't know.
Yeah, great. And do you think that if we use yeah, and I just look for your cases. Yeah, use the FARAPULSE and with 3D mapping. Yeah, high resolution mapping, and you will find some yeah connection between coronary sinus and posterior wall and almost the washroom of the coronary sinus. So maybe with the traditional checking method, just placing in left atrial appendage, we just look at the sequence of the coronary sinus. We just identify is blocked or is not blocked. Maybe that's not enough. Yeah, maybe yes, the high density mapping for the whole left atrial and also combined with CS mapping, maybe very important to identify the complete block of this isthmus. Yeah. Do you think we should mapping every cases should combine with the left atrial and the coronary sinus mapping?
Yes, I agree on that because I think the best way to demonstrate the mitral isthmus block is the high density mapping. If you use traditional mapping, when the coronary sinus is when the coronary catheter is near the mitral annulus, you can miss some cases of the gap in the ridge. You know, so so it will cost more time, and we do a study. We will use this every case in the high density mapping. But in the future, in the routine clinical experience, we think we didn't have enough time for every case.
Yeah. But for the mitral dependent atrial flutter, maybe is very necessary for us to map the two anatomic. Combine map the two the structure. Yeah, left atrial and the coronary sinus. Yeah,
yes,
maybe.
Yes, I agree that. Especially in the redo cases, we will put more time to check the line, if to see if it's really blocked or if it's durable.
Okay. Thank you for your wonderful sharing about these cases. Okay, and later Dr. Zhang will chair the other two speakers. Yeah, Dr. Zhang, please.
Okay. The next speaker is Dr. Q Chin Chi from the Singapore. He will introduce the PFA practice in Singapore. Let's welcome Dr. Jin. 他是线上吗？
Thank you, Chairman, for the kind introduction. It's a pleasure and honor for me to share with you my initial experience using pulse field ablation in treating atrial fibrillation. These are my disclosures. We had the good fortune to use pulse field ablation from October 2022, and we published the results of the first 101 patients in December 2024. This population comprised mainly of men. Close to 80% had paroxysmal atrial fibrillation, a fairly young study population of about 60 years old, and they all had normal left ventricular ejection fraction. We had experience with the Boston Scientific FARAPULSE system. It's a catheter that can be deployed in a flower configuration as well as in a basket configuration. Each has 5 splines with 4 active electrodes. The third electrode is available for pacing and recording EEGMs. I apologize for a very busy slide, but let me take you stepwise on the study population demographics, the procedural details, and the procedural success rates. Let's look at first, majority underwent general anesthesia. 3 out of 4 had general anesthesia. 9 out of 10 patients had a ICE catheter utilized for the procedure. In this index cases of 101 patients, close to 43% required concomitant CTI ablation, for which RF was used, more in patients with persistent atrial fibrillation. Additional ablation was also delivered using radiofrequency ablation. As you can see, we were able to use Cato, EnSite, and Rhythmia with FARAPULSE system. 100% of patients with persistent atrial fib utilize a concomitant 3D mapping system versus just 82% in paroxysmal atrial fibrillation. The smaller system was used, 31mm FARAPULSE system was utilized, up to 86% in this case series. A quick look at the procedural details. The left atrial dwell time a bit longer in patients with persistent atrial fibrillation, but it's an average of 41.3 minutes. The skin-to-skin procedural time hovers at about 2 hours, a little longer in patients with persistent atrial fibrillation. The follow time is a little higher compared to radiofrequency or cryoablation because it's a largely fluoro-guided procedure for the time being. Vagal response occurred in about 15%, but with the utilization of atropine subsequently, we hardly see any vagal responses. Let me take you through the number of applications applied to achieve procedural success in this series. Let's look at PVI. Those with persistent atrial fibrillation receive a higher number of total applications to achieve PVI. Now, if you look at the various veins, they all need more than the standard 8 applications recommended per vein. You would see it ranges from 9 to 10 on average. Some patients required posterior wall ablation for various reasons. There is a narrow gap after achieving PVI. There is low EGMs on the posterior wall, or a persistent atrial fibrillation patients who require posterior wall ablation as an additional strategy. Now, if we do posterior wall ablation in the left atrium, more patients require that strategy in persistent AFib. 2 out of 3 patients with persistent AFib require that versus just less than 1 out of 5 in paroxysmal atrial fibrillation. The number of applications required to achieve posterior wall isolation was higher in those with persistent atrial fibrillation, 20.1 or 20.9 application versus 15.1 applications in paroxysmal atrial fibrillation. So for total PFA applications using the FARAPULSE system, in those with paroxysmal atrial fibrillation, they receive an average of 47 versus persistent atrial fib with an average of 61.3 application. Our experience is aligned with what was reported in real-world cohorts, that PVI is achieved in both group of patients with paroxysmal and persistent atrial fibrillation. If posterior isolation is desirable, it is feasible and successful without any increase in procedural and fluoroscopic time. And in this initial series, up to 43% of patients require additional CTI linear ablation, for which radiofrequency ablation was utilized. A quick look at the results. Let me take you through. Acute successful PVI was achieved in all patients. Complications were low at about 6%. One had cardiac tamponade, one with acute respiratory failure, 2 with excess bleeding as well as hematoma, and 1 with catastrophic retroperitoneal hematoma. All-cause mortality were 2. They were unrelated to PFA. 2 patients had heart failure hospitalization, and the 12-month recurrence rate was at 12% in the whole cohort, 10% in paroxysmal atrial fibrillation versus 19% in those with persistent atrial fibrillation. Up to 15% of patients required or received antiarrhythmic drugs at follow-up, and 3 patients underwent redo ablation. This is the graphical representation of the arrhythmia recurrence at 12 months. For all patients, those with paroxysmal atrial fibrillation had a freedom from atrial arrhythmia of up to 90% versus 79% in those with persistent atrial fibrillation. If we have a deep dive into patients with paroxysmal atrial fibrillation only, the strategy of PVI plus posterior wall ablation did not differ from those with PVI only. And the conclusion of our study was that PFA is safe and effective for AFib ablation. In our series, majority underwent general anesthesia. They had received an ICE catheter for guidance, and 3D mapping was utilized. If needed, left atrial posterior wall ablation may be done safely and effectively. There were no RFA-related complications, and the 1-year success rate was at 90% for paroxysmal atrial fibrillation and 79% for those with persistent atrial fibrillation. Let me share with you some lessons learned in our journey. We found that ICE is tremendously useful. Durable lesion creation requires good catheter contact with tissue, and the ICE catheter is able to assist and achieve this directly or indirectly with real-time visualization of the catheter tissue contact. It also assists in appropriate transeptal puncture so that we could align or position the catheters adequately. Let me show you some videos. On the left is an ICE imaging with the catheter in its basket configuration at the os of the LSPV, and on the right is the corresponding fluoroscopic image. You are able to visualize and appreciate the contact of the splines of this catheter against the osteal surface of the LSPV, and the LIPV could be seen with its osteal opening as in its off-axis view. In the same manner, you are able to change the configuration to a flower configuration and advance with a slight eversion to ensure good contact on fluoroscopy on the right side. And that is shown very clearly and elegantly on the ICE imaging. You will be able to appreciate that the catheter is advanced, and as it everts, is in adequate contact with LSPV. And with that, you deliver your pulse field application to achieve PVI. In the same manner, you may then maneuver the catheter to achieve good osteal opposition of the LIPV. The image on the left shows clearly in its basket configuration that the splines are in good contact on the with the surrounding LIPV osteal and antral region. And this is a demonstration of the catheter being advanced in its flower configuration to achieve slight eversion, and that demonstrates good contact on fluoroscopy and on ICE. In the same manner, the right-sided veins may be visualized adequately to assess tissue contact as you pulse the pulmonary veins. In the beginning, CTI was done with RF ablation. Gradually, as we gain more experience, we begin to use pulse field ablation for CTI ablation too. And on this screen here, one is able to visualize the CTI and the catheter in a small basket or powerball configuration across the CTI. Further down is the RV, and this catheter lies clearly and nicely in good contact with the ventricular end of the CTI. If the position is adequate and suitable, we will give IV GTN at least 1 milligram up to 3 milligram before we pulse the CTI, so as to avoid unintended coronary vasospasm. And after pulsing at the ventricular end, and we normally deliver 3 pulses here, 3 sets of pulses, then we move the catheter back to the CTI. You are able to also see the echogenic material or echogenic ventricular end of the CTI, showing that there was effective ablation done. Likewise, there is good contact on the CTI proper, and we pulse 3 sets of pulse over this site, and we withdraw the catheter to the IVC end of the CTI and pulse accordingly. And at the end, you are able to see the echogenic CTI due to effective ablation. And this is a picture showing, representing what we did. This is a patient who came or organized to CTI-dependent atrial flutter, And as we pulse, and as we reach the IVC end, and the last few pulses resulted in termination of the flutter, and we went on to ensure and assess that there is bidirectional CTI block. We are able to use the catheters to create a geometry on the go. This video demonstrates that very nicely as we use a Farapulse system, as we map the left veins and pulse it in its basket and flower configuration. You are able to see that we are collecting geometry on the go. On the lower panel, when the saturation of the electrogram is when we deliver pulses. In the same manner as we move the catheter to the RSPV or the RIPV, as we pulse, one is able to record the EGMs and create geometries as well as a qualitative map of the left atrium. And this can be done because for the Farapulse system, be it in a flower configuration or a basket configuration, the equatorial electrodes is able to record and paste as needed. And as you maneuver, and upon finishing and completing the PVI, one is able to create a fairly good quality geometry of the left atrium. The post PFA map would be of a qualitative nature, not of a high density map as you would use or you would achieve acquired with a high density multi-electrode catheter. On the left is the REO view and the PA view of a patient who underwent pulsed ablation to achieve pulmonary vein isolation and left atrial posterior wall isolation. You're able to see that the shadows of the splines in various configurations is captured to show where ablation was done. And in this case, we use a HD grid to map the left atrium, and clearly it shows a PVI as well as left atrial posterior wall isolation. The same could be achieved with the Cato system. The Cato system does not display the Farapulse splines in its basket or flower configuration. It shows as a circular configuration, and one is able to appreciate that post-ablation there is PV antral isolation, both on the voltage map as well as on the LAT map with scars or gray zones within the pulmonary veins. Other things that we learned is that in the initial case, this is case number 9, the first few cases that we did, because of the posterior bias of the flower configurations while pulsing the inferior veins, there is inadvertent posterior wall ablation, and you are able to see that there is a line with a small gap in the posterior wall. When we do map and make such observations, we would then pulse the posterior wall so as to avoid a posterior wall roof dependent atrial flutter. This is a case using the arrhythmia system to map the left atrium post PFA, and in this case one is able to appreciate that there is inadvertent ablation of the mitral isthmus, and that's because in the flower configuration at the LIPV, one may counterclock it and adopt a more anterior bias, resulting in inadvertent ablation of the mitral isthmus. Ladies and gentlemen, let me conclude my lecture by providing you an update. We have now analyzed up to 270 patients who have completed 1-year follow-up, predominantly done under general anesthesia, ICE usage, and 3D mapping. The acute success was almost 100% in PVI. For those who received left posterior wall ablation, 100% received or achieved isolation. CTI was ablated and conduction block achieved in 17 cases, as was mitral isthmus conduction block in 17 cases. SVC were isolated in 7 patients. There were inpatient complications or acute complications of 4.8% in 13 cases. As you can see, these are related to the interventional nature of AFib ablation. There were 2 cases of hemolysis or hematuria, whom we suspect could be underlying hemolysis. We did not do the markers, but none of them had acute renal failure. Recurrence occurred in about 8.4%, 22 cases, of which 16 had atrial fibrillation, 2 had atrial fib and flutter, 2 had atrial flutter, and 2 patients had macro reentrant atrial attack. Thus far, there is no PV stenosis, atrial esophageal fistula, or chronic phrenic nerve injury thus far. And so that has been my experience using pulse field ablation for AFib ablation in Singapore. Thank you for your attention.
它这个是线上的是吧？啊，录播那就播下一个吧，那就播下一个，就是那个刘强是也是线上吗？好，那就直接放吧。
Good evening, everyone. It's my great honor to take part in 2025 Asian Cardiovascular Clinical Research Seminar. I'm Qiang Liu from Shuangruansha Hospital, Zhejiang University. Today, my topic is about our past single-center procedure workflow. It's about low floral ablation in our center. All procedures were performed under general anesthesia with endotracheal intubation. The patient exhibited no significant muscle tremor, and the 3D model showed no displacement, thereby ensuring the smooth progression of the entire ablation procedure. For paroxysmal atrial fibrillation, a standard 32 ablation was performed to finish PV isolation. If the intrapulmonary vein ridge is thick, additional ablation would be performed in this region. For persistent atrial fibrillation, box ablation and posterior wall, roof, and mitral isthmus linear ablation were performed. The hallmark of our center lies in its comprehensive integration of real-time multimodal imaging guidance, like eyes, floral, and 3D mapping throughout complex cardiac interventions. The ultrasound guidance was utilized throughout the entire procedure, from initiation to completion. Due to the use of large bore sheaths, muscular exercise for all patients were performed under ultrasound guidance, and no procedure-related vascular complications have been observed to date in our center. After femoral vein exercise, patients were hypnotized, aiming for activated clotting time of 300 to 350 seconds. Then we insert eyes to confirm pericardial infusion status and exclude thrombus in left atrium and left atrial appendage. Under the guidance of eyes, applications of electrocautery to J-wire in the deflectable sheath were used to perform a single transeptal puncture. The tendon side was adjusted to face the left appendage to confirm optimal puncture site slightly lower and anterior. With gentle withdrawal of the J-wire to expose just the tip out of the sheath dilator. The electrocautery generator was set to electrocoagulation mode with a power and 20 watt. The cautery pen tip was placed in contact with the proximal portion of the guide wire and energy delivered. If the white smoke at the tendon site could be seen in the left atrium by the eyes, the J wire was then advanced into one of the left pulmonary veins, and then the transeptal sheath was advanced along the wire into the left atrium. For PFA isolation, the PFA ablation protocol consisted of pairs of energy applications. For each PFA, one pair of applications was performed in a basket configuration, and then the basket was rotated about 36 degrees to change the spline orientation before another pair of PFA applications was delivered. It is very important to make sure when we rotate the catheter, each spline should be rotated at the same time, and there was no gap formation during ablation. Based on our experience, when we rotate the catheter, we should slightly pull back the catheter, and then after you rotate the catheter, then you push the catheter inside the ostium of the PFA to make sure its spline is contact is rotated, and there was no spline just located at the same position as before you rotated the catheter. There are, for example, just use the eyes imaging to confirm the contact of the basket or the flower during ablation in each PFA. This is the LSPV. We can see the basket just inside of the LSPV ostium and the contact good. Then we use the flower to ablate the LIPV, and we can see the contact, the flower, the catheter, using the flower configuration, just touch the ostium outside of the LIPV. Then we slightly rotated the S catheter. We can see the RIPV. Using the basket, we just put the basket inside of the ostium. When we ablate the RSPV, we just using the SVC view of the eyes. Then the basket, we can make sure the basket just inside of the RSPV and the contact good. When we change the configuration of the catheter from basket to flower, we can get it by the S imaging. This example, we ablate the LSPV. We put the catheter inside of the basket just inside the LSPV, and then we change the basket to the flower. During manipulation catheter from the left side to the right side, we also can get it by the moment of the catheter, get it by S imaging and the 3D mapping system. We can rotate the S imaging, follow the catheter movement, and make sure the flower can we use the flower configuration during move the catheter from the left side to right side. It's very safe, and we can follow the catheter from left side to the right side. During PFA ablation, the S imaging is very important to guide and confirm the coaxial alignment and the contact This is there are 4 examples of the of the PVA ablation. This is the LSPV ablation. We can see from the S imaging the basket inside the ostium of the LSPV. And this is the LIPV. We use the flower configuration, and the flower contact the outside of the LIPV. For RIPV, we just slightly rotated the S caster. We can see the ostium of the RIPV and the basket, the caster using the basket configuration just inside the RIPV. The contact is good. During ablate the RSPV, we use the SVC view of the S imaging, and we can see from this is the SVC, and this is the RSPV, and we can see the basket is contact. The basket is just inside the RSPV, and the contact is good. For EP doctor, it's very important to know the lesion formation, the voltage change before and after ablation. So for each patient, we did the voltage mapping of the left atrium before and after atrial fibrillation, the PVA isolation, and we can see the lesion formation around the PVA ostium. For persistent atrial fibrillation, the additional ablation is about roof, left posterior wall, and the mitral isthmus. All the ablation could be guided by X imaging, and we can guide it by S imaging and the 3D mapping system to using the flower configuration to make sure the contact. This is the left atrium posterior wall ablation. We can see the flower just touch the roof of the slightly close to the LSPV. For each side ablation, there was 30 to 50 overlap. This is the example. We ablate the mitral isthmus, and guided by X-ray. At the beginning, we can. At the beginning, we guided using X-ray. So far, we just use the 3D mapping system and the X imaging. We can confirm the position of the caster, and the contact could be confirmed by S imaging. For each side, there was 3 to 4 flower ablations with 30 to 50 overlap in 3D mapping system. Before ablation, before the mitral isthmus ablation, we will introduce nitroglycerin to protect the coronary arteries better. This example, we did voltage mapping before and after posterior ablation. We can see the big box lesion formation post ablation in this persistent atrial fibrillation patient. This is our early data about the bypass ablation for paroxysmal atrial fibrillation and persistent atrial fibrillation, and we can see compare the two different patient. For persistent atrial fibrillation patient, just the little ablation time increased. Most of the time spent to the preparation, like general anesthesia and the femoral vein puncture. So far, just using the workflow guided by ultrasound, there was no procedure complication and the immediate success rate is 100%. And guided by S imaging, we can finish the procedure using non-fluoral in some cases, and most of the cases, just a little radiation time used. Finally, coming to the conclusion, the PFA using for pulse catheter is a feasible and safe ablation approach for PVI or PVI plus in patients with paroxysmal and persistent atrial fibrillation. Guided by S imaging, we can achieve procedures with minimal to zero fluoral radiation exposure. Thank you.